Okay, good morning, everyone. Thank you for having us. It's a pleasure to be able to present the work. Dr. Hebe, that was very interesting. We actually asked kind of a similar question directly related to the critical view of safety. So let me tell you kind of what we were able to accomplish here. So we have nothing to disclose. So as you all know, bioduct injury rates have not decreased since the introduction of laparoscopic cholecystectomy, still stuck at around 0.3%, and of course this is a bad problem to have. So the accepted method to avoid a bioduct injury is to achieve the critical view of safety. And I think most of us could define that pretty readily. Obviously, you need to clear the triangle, you need to get the lower third of the gallbladder up off the cystic plate, you need to see two and only two structures entering the gallbladder. And I think all of us could probably quote those 6 criteria in our Sleep from the Safe Cholecystectomy program. But if you look at some of the recent studies that have been done, it turns out that there's a large percentage of surgeons who are actually not achieving the critical view of safety in their laparoscopic cholecystectomies. These 2 pictures are actually from a study by Daly and colleagues who sent 5 pictures, intraoperative pictures, to a group of about 350 surgeons and asked those surgeons to choose which one was the critical view of safety. And it was this one. But about 20% of surgeons chose pictures that were not the critical view of safety, which is very interesting. And so the question is, if you were to look at this curtain behind me, I would say that it's blue. You might say that it's blue, but are we really looking at the same color, and are we calling it the same thing? And it's the same problem with the critical view of safety. When we're both looking at the same intraoperative anatomy, are we really seeing the same thing? And when we've performed even the same dissection, do you and I both see it as an adequate view of the critical view of safety? So this was the question that we wanted to answer. And so to accomplish that, what we did is we collected a library of 20 laparoscopic cholecystectomy videos. For 10 of those videos, we sampled a 1-minute section that was early in the dissection, and for the other 10 of those videos, we sampled a 1-minute clip that was immediately prior to the critical view and the division of the cystic artery and the cystic duct. And so we created an electronic survey where we sent those 20 video clips to all of the residents and faculty in our general surgery program, and we asked them to tell us, do you think it's safe to clip and cut the structures in this video? And that would tell us, by comparing the consensus on those 2 questions, whether people are seeing the same critical view of safety or not. And to further investigate what's going on in people's minds, we asked them to also say, if this is not a safe view to clip and cut, what further steps would you take to achieve the critical view? And all of the participants were of course, blinded to the what actually happened in the video. So they didn't know whether it was an early dissection video or a late dissection video. So we also use kappa statistics to measure this. And this is just a brief introduction to kappa statistics. The bottom line is that if you don't have at least a 0.6, then you're not even at a moderate level of agreement. So let's look at some of this. Among all of the raters that responded to our study, there was agreement of only 0.25, which is very, very low. So we thought, well, maybe that was affected by having a bunch of residents answer this question. The residents didn't agree with each other within the group. So then we asked, well, are at least the faculty agreeing on what is an adequate critical view? And it turns out that the faculty did not agree either. So then we said, maybe this is affected by subspecialties. Maybe everyone in the ACS department is seeing one thing, the MIS is seeing something else. It turns out that the minimally invasive surgeons did have a higher level of consensus within the specialty, but it was still fairly low. And there was also no agreement between subspecialties. For example, as a group, the HPB surgeons didn't agree with the MIS surgeons. So then we wanted to say, basically, these people who are watching the videos, how well did they agree with what actually happened in the operating room? So this is a picture where we mapped every responding faculty member onto a grid of how well they agreed with what actually happened in the operating room. You can see that almost no one who was evaluating these videos had even moderate agreement. There was one surgical oncologist who had moderate agreement with what happened in the OR. But no faculty and no residents had more than that level of agreement. So the next thing we did is we noticed that there were 2 videos that had 100% agreement by everyone who watched these videos. They said, please don't cut these structures. And so we said, maybe from this small island of consensus, there's some lesson that we could learn. And so we looked at, what did people say that they should do to achieve a critical view given what we're seeing in these videos? And people were able to free text that answer, and we noticed that they fell into essentially 5 categories. So these were sort of the best moves that were recommended by the people who rated these videos. And it turns out that the faculty had no agreement whatsoever on what was the next move that should be made to achieve a critical view. The residents also didn't agree. And we also broke that down by how senior were the residents. Perhaps the chiefs are operating or have some level of agreement more than the interns, and that's also not the case. Now, there are some limitations to this study. Obviously, our response rate was low. We didn't look at whether we actually had any bile-duct injuries. And of course, there's the possibility that someone could have recognized their own video and rated that differently. But the fact remains that there's a surprisingly high degree of variability in surgeons' perceptions of the critical view of safety. So when you dictate that you've achieved the critical view of safety, and when I dictate that I've achieved the critical view of safety, we may not have actually achieved a similar dissection at all. Interestingly, this persists both within specialties and across specialties, and also across all levels of training. So the question is, where do we go from here? And I think for all of us to make a meaningful commitment to achieving the critical view and to prevent bile-duct injury, it may require basically incorporating large numbers of video reviews or training into how we train our residents so that we can all be calling the color blue, and calling a critical view, a critical view. Thank you.
Thank you.
Question, please.
Thank you for another very well presented paper and asserting that HPB surgeons and MIS surgeons don't agree, which is a good thing. So my question for you is about how do you convert a subjective thing to an objective thing? And we found that if you use, for example, the doublet view, which the doublet criteria by WashU, it actually, and you ask people after they rank the doublet view using the doublet scale, and then you ask them, did you achieve the critical view of safety or not? Then there's actually a very good way, a good correlation between actually achieving it or not. Does that make sense? Did you see that at all, or?
Well, so by using the videos, I think we were able to give people a much more comprehensive idea of what was happening in the operating room.
But I guess my question is, if you asking a global yes, no, is very subjective versus rank the critical view of safety using the doublet objective criteria, I think is way more objective and gives you the answer better.
Right. I think in terms of applicability, the question that we all have to answer in the operating room is, am I going to cut now or not? And so that's why we chose this approach.
Hi, good morning. It was a very nice presentation about the critical view of safety. I'm Dr. Siddiqui from Jeddah, Saudi Arabia, and we have experience of dealing with quite a number of difficult lab colleagues. I just wanted to give a comment, and I agree with Dr. Maurice Arigui that nowadays the new surgeons, they are not exposed much to open cholecystectomies. And the same case was with me also. But there is one factor, those surgeons, I think, who are repairing biliary injuries done by other surgeons, they are much more cautious. They give more time to their critical view of safety, even in cases of difficult lab choles, and I think they have lesser incidence of having biliary injuries. Thank you.
I mean, obviously, the video selection, quick question. You selected them. I mean, this is basically, why were those videos in particular selected and not others?
That was a sample basically collected chronologically across 3 different specialties from our acute care surgery division, the MIS division. And
my point is that your videos are an anterior dissection of the callous triangle. Why not start posterior to the callous triangle and then see if that will affect your outcome?
Yes.
As a suggestion. I mean, one more question, please.
Yes, a quick comment. I think this really reinforces that no matter who we are, the bile duct and the gallbladder and the potential for bile duct injury really exists no matter how experienced you are, you're a faculty member, a chief resident, you can't be cavalier. And one rule that I have instituted, which I think is a good one, because many surgeons who call me with their bile duct injuries, which I repair, a common comment I hear from them is, I was working along, it was great, I took the duct, and then 5 minutes later I figured out I had a problem. And I think that if one comes to the point that you're ready to cut and you simply tell your residents, you need to take another 10 minutes by the clock and continue to dissect, you will elucidate some anatomy that you didn't expect in a very small percent of patients, but that small percent of patients may be the ones at risk for bile duct injury when you think you have the critical view. Because your point is, when we think we have the critical view, we may not. So that 10-minute rule, after you're ready to cut, may save you a lot of heartache in the future.
It's an excellent point.